There's specialty centers in developing countries, called on-prem research certificates here.
Yeah, voice. 3, 2, 1. This is not just a debate about healthcare primarily, insofar as there's important nuances related to development. Because the common goal between healthcare and developing states is that they have a core principle of beneficence, basically doing good. I'm going to prove to you by the end of my speech that because of the specific state of these developing countries, the rise of specialty centers just does more harm than good. What does the rise look like and what does regretting it do in our side of the house? Number one, this primarily focuses on funding, given that the vast majority of specialty centers are publicly funded by the government. So we saw this in how the Heart Center was created or built by Imelda Marcos using taxpayer money. We saw this in the kidney centers in other developing states like Lahore in Pakistan or New Delhi in India. They're also using taxpayer dollars to fund the creation and expansion of these centers. Next, what caused the rise in the first place for developing countries? We tell you that the reason it has rose in the first place is because of the massive importation on the Western model of healthcare. So the vast majority of Western states like the United States do have a lot of specialty centers because they have more doctors, they have more practitioners, and the average income is significantly higher. If I'm going to tell you that these things are just inaccessible in their side of the house, it's significantly worse. But let me make this very, very clear. Just because we're regretting the rise doesn't mean we're abolishing these things. So we're still going to have the National Heart Center, for example. We're just going to limit the size and expansion of other things. So we're going to prioritize not just general hospitals, so hospitals that do everything at the end of the day. The comparative also looks like if there are going to be specialized centers that can be expanded, we focus on the most pressing ones. So the ones focusing on the heart, the ones focusing on lungs that are life or death situations. But other niche things like bone specializations can be just left to the other hospitals, given that other hospitals do have their own departments, a department of boneology or whatever. They have their own ways of dealing with it. First argumentation on why the opportunity cost is significantly worse on their side of the house. The premise here is very simple. Understand that developing nations are still very heavily susceptible to preventable diseases like malaria, respiratory issues, or diarrhea. Three mechanisms as to what makes these things so easily preventable. Number one, constant checkups to ensure that every couple of years you go to the doctor or you send your child to the doctor to make sure you're up to date with vaccines or to ensure that you're not developing any new disease. Number two, cheap and accessible healthcare so that in the instance where you do become sick, you don't have to resort to breaking the bank just to get a checkup or getting some aid, or you don't have to resort to alternate forms of medicine because you can't afford hospitals. But number three, specific types of information like information campaigns to know what to avoid, how to avoid diseases like dengue and diarrhea. The implications of this, therefore, is that you can't get this as much in opposition for four specific mechanisms. Number one, understand that with the rise of specialty centers, the vast majority of funding and the expansion of hospitals is often very expensive, that these services often rely imported materials and imported devices and imported knowledge, for example, from the Western states that can cost a lot more money. Therefore, the price for these services like heart transplants or whatever is significantly more expensive, making it less accessible to the average person or the masses. Number two, this is often highly focused and conglomerated in specific urban centers because of the higher demand. Because it is so expensive, only the rich people in places like Manila, for example, can afford it. Because even if, and this is just engaging, by the way, not assuming, there might be some privately funded health centers or specialized centers at the end of the day, at least in our side of the house, it is significantly better because they are incentivized to expand in more rural hospitals, or in general are incentivized to expand in rural and more far-flung areas, because in their side of the house they can still all conglomerate in a urban center, but the competition is based on the type of specialization. When everyone's doing the same general thing, they can expand better. Next, because the nature of specialized center is more often not reactive than preventative. You don't go to the heart center, for example, to have your yearly checkup or monthly checkup for your child. You often go there when you're at the brink of death, for example, or when you're about to die and when you need a heart transplant at the end of the day. So fourth, it's also significantly worse because the human capital, so the vast majority of new doctors or people studying to be doctors would rather become specialized doctors in cardiology because the pay and attention is better. Three impacts as to why this is worse in their side of the house. There is a important opportunity cost. So the funding that could have gone to public hospitals or other things just goes to these things that are not accessible to the average person at the end of the day. There are less general practitioners because people like college graduates who want to be nurses are less incentivized to go into general practitioner because there's just less money, because there's just less of a demand. But number three, the most vulnerable people are the average population. So the people who live in the provinces, for example, who have no more alternatives because they have no hospitals in that point because the opportunity cost fucked them over. Secondly, who are the most susceptible to diseases. And number three, yeah, they die more. Go, POI.
So general practitioners likely exist on both sides, and if we have that, we can treat the preventable disease that you have on that you push on our side. In the instances of like very complicated specialty treatments, how do you find resources for this and knowledge?
Again, both of these things happen in both sides. general practitioners can happen both sides, but we tell you that the opportunity cost means that the vast majority of them or more of them are incentivized to become specialized. And in terms of that thing, I'll deal with that in the second argumentation. Because their case is probably going to be, what about the more niche things? Two things. Number one, you can still get that in our side. You still have hospitals and private hospitals or even public hospitals like PGH who have their own departments for specialized issues. So in PGH, there's a department of cardiology for people with specifically cardiology issues at the end of the day. So in terms of research and helping those niche things, you can still get on our side of the house. Positive argumentation that proves why, absent the rise, hospitals are likely to be better off in our side of the house. Number one, it is more likely the fact that the vast majority of hospitals that are not specialized are based on preventative measures. Four mechanisms as to why this is true. Number one, it's more likely that in our side of the house, checkups are made more accessible when there is more funding with the expansion of public and average general hospitals in more far-flung areas. So families don't have to wait till their child gets a 40-degree fever until they choose to go to the doctor because it's so expensive. They can go every month, every year, because the price isn't as expensive. Number two, things like outpatient care, so free donation drives for vaccines, are more likely to manifest in our side of the house because the vast majority of these specialized centers have a very niche urban market. Their main interest is on appeasing their urban clientele. But number three, you are more likely, and on extents, you are more likely to have more people want to opt in to become general practitioners at the end of the day, given that there are more hospitals in places like the rural areas when you have more money, when you regret the rise in our side of the house. And given that hospitals can also serve as educational centers. So a lot of college bachelor people who study for nursing intern and actively continue their education in specific hospitals. So at least in our side of the house, when you have more of these hospitals can be more accessible to the average person in the province, in the mountains, for example. Number four, hospitals are also significantly near the vast majority of the population, so you don't have to travel like hours when it's a life or death situation. So the impacts of this are very, very simple. Preventable diseases, sure, if you can deal with them in both sides of the house, but on extent, it is significantly better in our side when you don't have that opportunity cost. Number two, these hospitals have more capacity because there is more funding. Number three, there is more buy-in within people to opt into these average and general hospitals. They don't all just flock to specialized centers. This is exclusive because in their side of the house, when you don't regret the rise of exclusive hospitals, there is no incentive to expand the public sector for hospital and healthcare because it is so profitable and people just don't want to do it. At least in government, we increase the quantity, which is the prerequisite for making these types of healthcare accessible, to making these preventable diseases like malaria more contained and to eradicate the core root of the problem at the end of the day. If they're rich, they can still go to a private hospital that exists on both sides. Thank you.
All right, we thank the previous speaker for this speech. Now to open the class for the up bench, we now call on Al.
Am I audible?
Yep, audible.
Okay. Get out! Okay, sorry. As someone who went through a tuberculosis scare last year, I am grateful for the programs of the Philippine Lung Center to ensure that the treatment and diagnosis are well communicated to me. I think that the existence of specialized treatment centers has allowed for the greater dissemination of treatment and increased the certainty of your disease being treated in the first place. The first thing I want to respond to is this idea on the counterfactual on being able to treat preventative diseases. I want to respond and say why we get to treat preventative diseases like dengue, like malaria better on our world. Because the assumption on Gabby's argument is that because we have to fund things like specialty centers, there are now less funding for rural health units and local hospitals to be able to treat preventable diseases like diarrhea, etc. But, and this is the flip to this argument, it was because of the fact that we have things like specialty centers that rural health units and local health centers are not burdened to treat specialized diseases like chronic kidney disease, like tuberculosis, like, for example, heart problems. That means that on our world, they were able to focus on preventative programs like ensuring that dengue doesn't proliferate in their local community. So that is the solvency on our world on how we get to treat preventative diseases, because now local health centers are not burdened to treat very complex and very specific diseases on their world. So if you want to talk about treatment of preventative diseases, it was because of the rise that it is better. But the next is why the rise has to exist in the first place. Because Gabby says that on their world, they still have things like Philippine Heart Centers, etc. But the difference is those things do not expand. I say when those things are not funded and those things are not expanded, that is worse. Precisely because on their world, that is a world in which the Philippine Heart Center gets to cater less patients, gets to do less programs, gets to fund less machines to treat things like heart diseases. So if they want to talk about access of treatment, it is on their world where people never get to treat their chronic kidney disease, precisely because the resources of the Philippine Kidney Center is lessened. On their world, it is where those centers are are underfunded but are still burdened to be the medical authority on diseases on a certain organ, I think solvency is much worse on their world. The next thing I want to do then is to talk about in framing on why the rice had to increase had to come to be in the first place. They said it's because we're just being gaya-gaya towards our Western masters. No, there's a specific reason why things like the Philippine Lung Center were created in the Philippines in the first place. The first is that prior to the creation of specialty centers, the wing system in hospitals, so things like the lung wing, the heart wing, for example, and like the other wings, were severely underperforming. And that's because in a general hospital, resources are split into creating and to funding these different departments. What that means is there's not enough resources for these people to fund, for example, things like machines, not enough money to hire enough specialists for people on the ground. And even if they have things like treatment centers, it is only to the surface level. So if there's a kidney wing, it's likely just on their world, it's only things like dialysis machines instead of advanced diagnostic equipment. There's less amount of specialists and they're often in rotation across different provinces. So the certainty of treatment is much less. But second, and this is the importance of the developing country context, is that there's a strong prominence of disease centered around a certain organ. Talk about the Philippines, one of the hotspots for respiratory and pulmonary diseases in the world. It was because of our tropical predisposition that meant that it is important for us to create a center that is specifically dealt to be able to do things like this, right? So that means that these diseases are severe and these things affect the everyday lives of Filipinos and other members of the developing countries, which necessitated a center that is the authority to be able to ensure that we get the proper treatment for the worst instances of these diseases. What does the rise then look like? Because I think it's likely to be one that is just deliberate, precisely because of the context of a developing country where there's not enough money, therefore you have to discern on which centers you have to create. There's budget constraints, there's demand assessment, but further is that the reason why we created them is after the recommendation of things like the Philippine Medical Association, right? So it's a mix of things like prevalence studies and talking about in the annual convention. The difference is on our world, we have a specialized center where we redirect all the specialty diseases so that general hospitals and rural health centers can focus on the things that are everyday concerns of people on the ground. So we get ensuring preventative diseases and specialty diseases, which is much better on our world. Argument then, why the rise of specialty centers has increased the certainty of treatment options. And I want to be clear because I already made the counterfactual quite clear, right? The first is that you consolidate knowledge and funding to one center only, because on their world, funding is fragmented across different regions and different centers and different provinces. It's likely to only have, for example, base level machines, etc. Second is that specialists are not connected and are expected to compete against each other because they're a hospital versus hospital competition. The delta is the money spent on our world is corroborated to create one center that can specially deal with dealing with these diseases. So it's a better budget management system because we allow a better allocation of funding, right? What's the POI?
Are you expecting people from Mindanao to fly over to Manila to go to the lung
But
center
here's
on
the
your
beauty
side?
of this, right? On our world, we have things like telemedicine, we have things like remote consultation, and we have things like diagnostic centers in the region to ensure that you don't have, for example, tuberculosis for you to not do the travel, for example, to on their world. But then that also begs the question of their counterfactual, because if someone in Mindanao has severe tuberculosis, how do they deal with that if their hospital is still underfunded and the resources are still split into the different departments? They never get treatment for anything. The second premise of this argument is that because of these centers, you've created an official entity that allows to lobby better treatment, precisely because you now converge all of the specialists in one area, which means that they get to do things like research, they get to do things like policy recommendations, to lobby for increased funding, and to lobby for things like of preventing these diseases. For example, the critical mass allows for better collective action and put forward the importance of treating these certain diseases, which is comparatively far more difficult on Gov because now they have to compete with each other. The third premise of this argument is that on our world, we have created a clear referral for certain care versus a poor attempt on treatment on side government, because now doctors don't have to burden themselves with treating chronic kidney disease and can just simply refer you to a specialist, which doesn't exist or are not as prominent on our world. That means means general hospitals are not presumed and pressured to treat these patients that they cannot take care of. I think there's a higher degree of success on our world. But lastly, and this is how I do the regional argument, is that you increase the prominence which trickles down to regional hospitals through 5 mechanisms. The first is they do things like calling for interns from state universities to intern in the Philippine Lung Center, etc. But second is you cascade different treatment methods. So for example, TB dots was the brainchild of the Philippine Lung Center, which increased the treatment and the prevention of TB. Third is extension work. So they extend to the different regional hospitals for treatment. Fourth is telemedicine and consultative nature, which allows them to talk to the different doctors. And last is prevention campaigns, which are only possible if you have a clear authority of who should treat these diseases. Proud to oppose.
All right, we thank the previous speaker for the speech. Now calling on the speaker.
Hello, POI's through voice. I'll just ring. I'm taking timer. Okay. Starting my speech in 3, 2, 1. The rise of specialty center is a cancer that kills the medical progress, especially in the global south. The rise of specialized care is another 3 to 5 hospitals that is gone from rural areas. And the further that many of these hospitals are gone is the higher mortality rates that you find in many of these rural areas. I think this is a retrospective debate, so we cannot necessarily put a premium on future impacts that is likely going to happen on opposition's world. The first thing I want to attack is that, do we necessarily need a lot of these specialty centers in order for you to cure a lot of the diseases? I think number one, on our side of the house, departments can still exist in general hospitals where EMT offices and cardio offices still exist. Many of the time, preventative in local centers is more important, in contrast to specialty centers that is often create a lot of geographical issues. It is about massive funding that goes towards special centers versus the expansion of prerequisite care that most often people need in order for them not to even end up in a specialized hospital to begin with, given the fact that access to general healthcare or general medicine or the ability for your child to access pediatric care all the time are things that are necessary in order for you not to go towards things like specialty centers to begin with. But number one, understand that they also gave good analysis. Why not just simply focus on treatment wings to strengthen them in order for them to perform better versus specialized centers that are only 1 to 2 locations, and that is generally farther. Imagine in India, if you're someone from Raipur, you have to go to Mumbai in order for you to get a dialysis, or even for you to get things like like the ability for you to get like a heart transplant, in contrast to you having a lot of those preventative care that you already have within your own specific areas, so you won't necessarily need them in the future. Understand that many infectious diseases that often happens in the global south are things that can be prevented, but we often don't, given the fact that we've spent a lot of funding in order for us to prop up a lot of already existing general care. The second thing that they say is that, well, we have a lot of future benefits. Like, for example, we are likely going to get more talent and more ability to spread research. Number one, that's the problem in and of itself. You take a lot of talents from regional interns in order for them to serve within urbanized centers for them to get access to that research, versus generally everybody having that own specific wing that creates their own research and own capacity in order for them to solve a lot of that issues to begin with. The second thing is that they say is that we remove a lot of burden for the general healthcare. I think number one, that's just generally untrue, given the fact that treatment is also uncertain on their side of the house. PGH still treats a lot of heart attacks, even if we have the National Heart Center, given the fact that they focus on more specialized and niche operations and even procedurals. So I don't think that they generally take care of things like cardiac health for general populace or the general society at best. So therefore, a lot of them still are stuck. And therefore, a lot of Gabby's analysis on the fact of the matter is that many of the developing world face a lot of structural inefficiencies. Like, for example, we lack a lot of general practitioners, given the fact that everyone sees more prestigiousness and more specialized areas, in contrast for you to have a lot of more individual people that is likely going to enter this field, because we see things like malaria or dengue are as a low concern certain things, even though they're just generally urgent within a lot of these areas. The second thing, I want to minimize their harm. They say that we fragment a lot of the health data. I think that's good because now there's a consensus of data across the entire nation, in contrast to you just having more individuals just getting getting certainty access in urban areas versus rural areas who can't necessarily fly towards those urbanized centers. I think number one, there's also good fragment given the fact that you spread a lot of specialized doctors. That's something that we claim on our side of the house, that people are likely going to, even if they specialize, they go towards things like general hospitals. The last hurrah that they had is that, well, if the location is the problem, let's have telemedicine. That's just generally ineffective given the fact that if we're talking about procedures, the ability for you to see a doctor immediately, the ability for you to have medicine at right now means that telemedicine don't necessarily work for more urgent cases that you need public hospitals in order for you to have it to begin with. I think number one, we can trade off a lot of the vulnerability because people who need access to things like heart operations or dialysis are often privileged individuals from urban centers, so therefore they can find other alternatives to do so. But understand, when it comes to scale and magnitude, many rural areas die from a lack of preventative care, and a lot of their children often grow up stunted. That makes them less resilient to a lot of future diseases, that makes a generally unhealthy population in the future. So in conclusion, a lot of the implications of these responses destroys the solvency on their side of the house. But I would like to explain as to why we are the prerequisite for any benefit that they have. One, buy-in and trust within the medical sector is generally lower because more specialized centers are on the rise, and therefore it impacts a lot of the proximity towards general health issues that people often face. Number one, specialization often creates an emergency-based needs capacity in order for them to take in a lot of these types of individuals. It takes away from general doctors, preventative care, or even a culture of consistently seeking care to begin with. So that means there's a focus on curing already a lot of these alternative diseases. But now there's not necessarily a premium on things like general checkups or the possibility for you to get a lot of general diagnosis to see if you have issues to begin with. What does that mean? I think number one, it produces a lot of lag time before you even get recommended to the specialty centers. You need to wait long times because there's a lack of general doctors, medical technicians, and even the lab results for your general diagnosis in order for you to catch issues early are things that you don't find on opposition's world, given the fact that the rise is such on a massive scale and a speedy scale, but also at the same time, the premium on funding for more public funding towards the government often goes towards these types of things. I think the prerequisite then becomes that we need a rise of medical centers that is not inherently specialized. So you don't need to necessarily get expensive procedures later on, given the fact that we tackle a lot of those pulmonary diseases or your health issues, things like asthma or things like skin diseases within hotter climates, are things that we prevent on the scale, given the fact that number one, this is the impact. Stronger relationship on your community doctors, given the fact that parents in poverty communities and even rural areas have strong relationship with their pediatric doctor or community medical professional. That means that medical care does not start once you are retired, because most often than not, a lot of these specialized doctors only see older people who already have massive concerns about their health. But now we are more likely taking a premium stance on you getting that medical preventative care to begin with. I think this solves a lot of problems in opposition, that now we don't necessarily increase the access of a lot of these general services, but also the proximity of an average individual, so that they don't need to, number one, self-diagnose themselves through things like online medical care or things like Facebook or things like alternative medicine, which is higher rates in South Asia, in a lot of developing nations, and there's less funding for general infrastructure for medical institutions on their side of the house. Specialized centers are not necessarily proximate to the majority of people, and therefore we must address a lot of the funding issues first before we support this rise to begin with.
Right, we thank the previous speaker for the speech. Now calling on yellow.
Hi,
Yep, audible, visible.
I'll take PY's voice. I'll start the speech in 3, 2, 1, go. The first thing I'll do in the top of my speech is show why it is necessary. In the age of climate change and antimicrobial resistance, diseases evolve and spillovers are usually uncontrollable. There are viral mutations and genetic drift that exist within bacteria that specialize in the lungs and often evolve every time how they attack your lungs, attack your kidney, and attack your heart. The problem with most of these diseases is that they attack fast and evolve towards destroying the body's capability to fight them back. What this uniquely shows you is that there are diseases that specialize in attacking specialized organ systems within your body, and it is not enough within the comparative that exists in GOV to show as to how they can solve this problem, precisely because they never show the extent of funding, they never show how the information that consolidates within the centers is existing on their side. What GOV has to prove is how GP practice in the counterfactual is enough to create specialized diagnosis that is enough to combat the aggression of this disease. They do not do this at all. The first thing I'll do is engage within the argument of GOV that relies under the premise that it is expensive and often inaccessible, and this is why we should regret it. The first argument that they say in launch coming from PM is that the first, it's expensive because it is important. But I would note that most of the medical technology that exists within developing countries are imported. This looks like x-rays that you get from the UK. This looks like ultrasound that you get from Germany, because it's unclear to any degree as to why you do not import the existing general practice counterfactual that exists on their side. The technology that they also use are also important. That kind of symmetrize a little bit of the harm. But the next thing I'll talk about is as to how you actually capacitate general practice on our side. What we suggest coming clearly from Ben is that the rise of specialization centers also lessens the financial burden of general practice hospitals to have. That is, suggest that you do not need specialized medical technology, for example, to specialize in kidney biomarkers, because you do not specialize in kidney because the centers already have that. So even if allocations are limited on our side at the best, the financial needs of these general hospitals also lessen, and they are not as exaggerated because you only need general screening tests, such as blood chemistry panels or ultrasound. In fact, and the difference here is that we make general hospitals focus funding on better general diagnostic tools that would preempt the occurrence, for example, of tuberculosis or chronic kidney disease or liver cirrhosis. This looks like, for example, having better nutritionists, having more pediatrics, or having better panels for general screening tests. So if the difference is that people get this illusion because general practice is worse on our side, this is completely untrue. What all of these sets of responses show is because you do not overburden a lot of this hospital to also specialize in kidney because they do not have wings already. That means that they can focus funding and of course slip all of the harms that comes from Kim when they suggest that people lose trust on medicine. We suggest that they don't. The next thing that I'll talk about is how how just like this is inaccessible because of distance. The weighing here is very simple, right? Because the question that you have to ask yourself as to why people actually go to Manila to go to the heart center is, when does this actually happen? Because this actually happens only to the fact that the GP is no longer enough to treat your disease. That is suggest that if your liver cirrhosis is already at the third stage of in the disease, it is unclear as to why you should stay to that GP when they cannot treat you at all. So of course they refer you. So even if it's true that it's far away, that one travel to get treatment saves your lives. In comparison on their side, will they have to travel in that locality multiple times, but they do not get saved at all. So if it's the cost towards people on the ground, then it's better maximized on our side, precisely because that one travel saves your life. On their side, it is unclear as to how they do this at all. The last thing I'll talk about is how they say that these people do not get democratized because suddenly we don't have extension work. I think this is just not listening to everything that Ben said. What we suggest coming from Ben is that a lot of times Philippine centers, precisely because they are publicly funded, often have the mandate to also fulfill and help the public. That is suggest that they precisely do extension work. They absorb interns from far-flung regions in order to educate them, which is in fact better because now if it's true that they cannot all go to the centers, then you capacitate GPs more, precisely because the interns that you actually make better on our side, precisely because we consolidate the amount of networks, the amount of information that we have. They also do not get this. Very lastly, about preventative care, they also do not get this at all. All the things that they talk about diarrhea and stuff like that, are things that are solvable in both ends. It is not a clear benefit at all. What we suggest, in fact, is we increase the maximization of this preventive care. Insofar as you have a center that's specialized on how to prevent, for example, urinary tract infections or tuberculosis, which is good because if general practice already has preventative care, you supplement that precisely because you have specialized center. It is unclear to no ends as to why the extensive benefit that comes on their side is marginally much better, the POI.
So you talk about funding these state hospitals, but where does the funding of these state hospitals come from in your side? Hospitals like the PGH are already severely underfunded. We tell you in government that the money that went to the expansion of specialized center could have went to these things instead. So we are the prerequisite to your
So
funding.
we already engaged that. Even if it's true that the funding does get minimized on our end, it is better because the needs of this hospital also get minimized insofar as they do not have to need a dedicated kidney wing insofar as you already have a kidney center. What that means is that even if funding at the best is minimal, it is still much better because you optimize the use and the utility of that funding. On your end, you tune it out, you spread it out in the entire hospital, and it is where you get misdiagnosis. It's where you get deaths because you do not have clear diagnostic tools at all. Lastly, what is the comparative that they have to defend that they never actually answer coming from them? What we suggest coming from our side is that a lot of times the kinds of treatment that exist on their side will never be adequate enough nor fulfill any treatment for the patient. And this is true precisely because of the overburdening of GP hospitals that exist within the counterfactual, but also the competition between hospitals that prevent collaboration between doctors. So, for example, if you have multiple nephrologists from different hospitals, what happens is that hospitals usually prevent them to collaborate, and this is why you do not get research at all within the kinds of specialized disease that are already rising because of the context to which we live in right now. Their response here is very flimsy. They say that we can strengthen this, but to no degree do they illustrate why it is enough, and in fact is actually much better within the counterfactual that exists on our side. At the end of the debate, it is clear. If we talk about funding, clearly we show how this funding gets better used by general hospitals, but it's also that why these specialized centers are indeed necessary within the context of developing countries. All of the benefits that they claim about preventative care, about trust, about things that like the utility of funds are clearly on extents much better appreciated within the rise. It is unclear to any degree as to why they win this debate at all.
We thank the previous speaker for their speech. Now calling on Gov Whip Krieger.
POS through voice. Okay. Okay. Three, 2, 1. My Obachan died when I was 12. Her name was Fujiko. She lived in Bohol and she had diabetes. And for her to be able to get checked up for her diabetes, she had to always take a boat from Bohol into Cebu because there were no probable hospitals that took proper care of my Obachang in order to be able to continue living. So this is the picture that we're painting on opposition side. Because if opposition side claims that they are decongesting hospitals, we disagree with that. Because a vast majority of these specialist hospitals are in mega cities, are in urban areas, areas where people who need it the most cannot even access it, even if it's free, because you have to take a boat, because you have to take a plane, because you have to take geographical constraints that don't even reach these people in the first place. Leah extended by saying, you need specialized healthcare because these specialized people cannot get the help if their general doctors recommend them. We tell you, the first problem that we said is the people we're talking about do not even get the general doctors in the first place. It's a timeline problem. These people do not even have the access to these checkups to be even referred to these specialized healthcare people at the end of the day. But even if they did get referred, it's not like they have the capacity to be able to fly to Manila and Philippine lung cancer, like what LO did in this run. But even if that is the case, it is unclear specifically why exactly is it the burden on government side to solve these specific illnesses when we already weighed to you and prioritized that these illnesses that the vast majority of the population gets is far more urgent, helps far more vulnerable people, is far more proactive than reactive on opposition side. The first thing, so I'm going to talk about three main things. The first thing I'm going to talk about is preventable and common illnesses. The second, I'm going to talk about specific ones. Then I'm going to talk about research. The first thing to talk about is common and predictable diseases. The main thing that opposition told us about this is specialized healthcare centers means we can decongest general hospitals. 3 responses. The first thing is, if you wanted to decongest these hospitals, we give you the most direct way by actively building these hospitals retroactively, considering that we didn't need to spend on high-tech facilities and continue spending on hospitals that are literally beside each other in QC. We tell you, then the competition isn't a specialty based. The competition is geographically based in hospitals. You're far more likely to have an incentive to build them and place them farther apart. So if it's about decongestion, we're far better than that. Secondly, they don't even get the decongestion mechanism in opposition because number one, it is just logistically impossible for the people they talk about. It's hard to be able to fly. It's hard to be able to afford. But secondly, it's also geographically improbable considering that it's literally mostly in Manila. We're telling you that the rice specifically is a cancer because it is like a vacuum that concentrated all of the specialized centers, depriving all of the regions in the Philippines in favor of Manila. They said telemedicine and interns can fly out and capacitate other areas. But if opposition was talking about chronic health diseases and the worst of the worst based on their urgency, I don't think telemedicine is going to do anything to that. I don't think interns have the capacity to do anything about that. Because the only thing that they benefit on the opposition side is actual facilities and high-tech and high advancement in order for you to solve these things. Meaning, you cannot buy any of their benefits saying that they can expand it elsewhere, considering that they have these materials and these assets in Manila in the first place. Sure, PY.
Our claim is that a lot of these centers also do extension works and take in interns from regions. So why is that not enough to solve the
because
problem?
in order for you to get your proper chronic kidney disease, it is not enough to just give one machine, for example, to there. The vast majority of your diagnostic tools, treatment tools, and the best doctors that you say are so important are still in Manila. So the point is, we get that benefit significantly on government side. What about specific illnesses? We tell you that these specific illnesses, can still be dealt with on our side. On opposition side, maybe you have the ability to cure them and maybe help them reach a better life. But on government side, you have bare bones hospitals. Maybe it's not as good, but it has the ability to treat symptoms. If a person goes to sepsis, if a person gets, for example, a huge fever, you still have the capacity to make sure that they do not die in the first place. On the base level, we do not let these people die. But even if we assume they do get that, we're willing to trade it off. There's 4 reasons why. The first is on magnitude and scale. This is a developing country, and a vast majority of the statistics suggest that most of the people die in diarrhea, diabetes. Most people die in preventable diseases that were more likely to happen if we were just able to build more hospitals out there and not wait 2 hours just to get to the nearest hospital. The second thing is we're also talking about the most vulnerable people. Sure, there might be people that are dying of lung cancer right now or heart cancer right now, but what we are talking to about are people who haven't even had the proper capacity to be able to eat, to be able to afford stuff. These people have been cursed their entire life to be able to access this in the first place. The third thing we talk about is also about proactiveness, which by the way didn't they respond to. We tell you a vast majority of general hospitals allow for constant checkups for you to check and to check yearly for vaccines and the like. On opposition side, you get a lot less of that. That means those illnesses compound and become heart diseases and become lung diseases. While on government side, we significantly mitigate a lot of that because people have the capacity to go to their hospitals and so on. So if we're talking about the health of an entire nation, we are far better when it's not consolidated in Manila and consolidated in these areas. Extension works exist, but they are never enough. Last thing to talk about is research and the ability of people. They just said they can collaborate on their side, but that's symmetric because we're talking about the vast majority here of public hospitals. The hospitals that we get literally has information sharing. They're not private companies. But even then, the research that we get is far better because the research we're doing is literally targeted to the diseases that happen to the most of people. While on the opposition side, they're in their own talking about lung disease when this only happens to a select few people in comparison to the vast majority of diseases that happens. On government side, we do the most good to the most people, to the most vulnerable. The people that need a hospital right now can actually get it geographically and not just hope that maybe I can get to Manila and get to lung center. Thanks.
All right, we thank the previous speaker for that speech. Now calling on Uplift here.
The government case is reliant on the context that preventable diseases leads to specialized medical conditions. I'll deal with this direction later on in my speech. What I first want to do is to point out that the government does not respond to the other context that comes from DLO, that we need a lot of these specialized healthcare centers because these specialized conditions also arise out of things that we cannot predict. So things like erratic genetic mutations that happens in viruses, zoonotic diseases that we cannot meaningfully predict where it comes from, or things like climate change exacerbating the propensity for a certain disease to manifest in a certain population. Why is this context more important than the context of government that preventable diseases become the prerequisites for specialized conditions? Firstly, developing countries are the most vulnerable groups of individuals to the kinds of phenomena that DLO tries to point out. So things like climate change, things like zoonotic transmissions, because they're the ones who have less protections on net. But secondly, there's a great deal of uncertainty where these kinds of specialized conditions come from when they go from the unpredictable conditions that come from DIA, which means that when there's a great deal of certainty, that is where we must fund our resources too, because the consequences are grave. We cannot meaningfully predict what will happen next. So the next best course of action is to be preemptive and create these specialized healthcare centers. What is the mechanism and why is the creation of specialized healthcare centers the tipping point for us to treat a lot of these preventable diseases that comes from erratic conditions? Firstly, you have a centralizing body that's able to consolidate a lot of information. On the side of the house, there might be a lot of disaggregated specialized healthcare centers, but there is no incentive for them to collaborate insofar as these specialized healthcare centers, as Leah points out, also have the incentive to compete and hide their information away from each other. But secondly, when you have a centralizing body as the National Lung Center, you have a critical government agency that can act as critical mass to lobby against senators and congressmen for them to focus on this particular action point of agenda. What this means is that this just proves why the creation of these specialized healthcare centers, which are centralizing and critical, a lot of critical mass, is a tipping point for why we need to support the rise in the first place. The second thing I'd like to do is to talk about what government wants, the next direction that government wants to have, which is that, well, we need to first treat preventable diseases so that we can reduce the propensity for specialized conditions happening. Their mechanisms are as follows. The first is that the funding that goes to the creation of specialized healthcare centers on our side goes to general practice instead on theirs. Firstly, I think that the problem is just an allocation problem, which we already clean up coming from Ben. Ben explains that the concentration of specialized healthcare centers in NCR, for example, means that local hospitals have more room for checkups. They can hire more general practitioners. They can get more beds in the rooms that would have been otherwise used for specialized clinics. This satisfies the preventable disease metric of government. GovFib then says that it's about geographic distribution. But we say that if it's about geographic distribution, there are mitigatory mechanisms that allow us to breach the geographic gap. So things like extension work and cascading research and development. This means that even if you have general practitioners on our side of the house, we can instill these general practitioners with more specialized knowledge, such that even if they face a patient with a relatively more complex disease, they're able to act upon it and make the necessary next steps, like referring them to another specialized healthcare center on our side of the house. In government, You might have general practitioners, but it don't explain what these general practitioners are likely to do in the instance that the patient is someone with a complex medical disease. On their side of the house, these individuals would likely like go nuts and not do anything and just treat the same kinds of general practice medicine to these people. There is no solvency. Go.
If you say that everyone experiences these types of diseases and concerns, why do we need specialized centers if you can just simply create generic institutions that do address the problem that everyone has?
Because general medicine just deals with general approaches. They do not target the nuanced specialized characteristics of various disease. Yes, you might treat a headache, and the GP might give you I don't know what are medicines for a headache, paracetamol, but that won't treat the root cause. So you need to have specialized specialty centers on our side of the house. They can't say that you will still have specialized doctors in their counterfactual because they're shooting themselves in the foot if they want to maximize the benefit of general practice. Okay, the problem with GOV, second, is that they don't explain why the counterfactual is states and societies channeling funding towards general practice on their side. What Ben suggests is that local hospitals are likely to try to specialize because they can no longer refer their patients to specialty healthcare centers. Ben already explains why this counterfactual results in underperforming specialized wings in local hospitals themselves, because these local hospitals don't often have the resources and the knowledge necessary to treat specialized conditions. You have to accept this comparative that on their side of the house, local hospitals will still try to some degree specialize, even with the extents thing that, especially with the extents thing that comes from PM, that you will still have some sort of specialized wings. But but also, in addition, the logical conclusion of their case is that you can only focus on general practice. Like, they don't prove why the counterfactual shifts in a way that local hospitals, when they are devolved, just focus on general practice alone, when in fact often there is a need for you to specialize instead, because there are a lot of symptoms that you can't meaningfully act upon on. What does this mean? They have to accept the trade-off that local hospitals try to specialize to some degree, but they don't succeed because they don't have enough knowledge. They also incur higher costs because they repeat the same kinds of general treatment to otherwise specialized medical conditions. What I'm going to do next is to focus on knowledge sharing and why we have better knowledge sharing in our study house. I want to make it clear that for the prerequisite for doctors in government to be proficient is for them to have adequate knowledge. What are the reasons why they have lower knowledge generation in GovBench? First, there is no expertise because there is no incentive for you to do research. General practitioners are expected to do general practice and not research. You can only have that incentive, however, when you have specialty healthcare centers that are state mandated to do these kinds of things. But even if you do research in government, we explained that there is no incentive for them to cross-reference and collaborate because there are inter-hospital competition to amass the most number of customers. What is a comparative? On our side of the house, these specialized healthcare centers solve the collective action problem in government and allows them to forcibly consolidate all of these information so that they can arrive at more nuanced solutions. Compare this with government's mechanism of relying on the benevolence and the willingness of individual hospitals to share their information if they have information to begin with. The second mechanism that comes from them is that, well, you encourage more people to pursue specialization, but if they say that, but if that happens, surely that the market self-corrects anyway, because if people go to specialized fields, they would probably face a lot of competition. So there's a natural incentive for them to scale down and to seek general practice as well at the end of the day.
Right, we thank the previous speaker for your speech. Now the end the case for the entire bench. Now call on overtime here.
Okay, hello. Am I audible?
Yep, audible.
UPLB definitely makes it to the semifinals for two reasons. The first is that the counterfactual that side government gives is inferior to what is already existing in status quo, and you have specially mechanized this. And I note that this is important because if they agree that specialized diseases are just as important as general diseases, then they had to give a counterfactual that is able to meaningfully address both. If they agree that specialized diseases are actually urgent and are very important diseases that we have to deal with in developing countries, how do they make the solutions accessible to regional people and vulnerable individuals in the first place? At best, and I want to tear down their mechanism, at best, the funding that is spent on organ centers are ones that are dispersed to the regional general hospitals, but it is unclear why that trickles down to meaningfully accessible healthcare on their world. And I want to quote Kim here. They said they might get 3 more hospitals, but that's just 3 more hospitals. It's not enough to cover the demand that they put upon themselves. Let's be clear. The math is not mathing because it's not meaningful for you to break down the budget you spend on these and meaningfully trickle it down to the burden that they want to give. Therefore, it is unclear what the extent of the benefit is, and that if it's meaningfully better than the benefits that exist on OP. If they want to talk about preventing general diseases, for example, like headaches, like diarrhea, like those other things, how are rural health centers and general hospitals better able to deal with this on their world? They say that, well, it's because they get more funding, and that because they get more funding, etc. Right? But what we told you coming from as early as LO is even if they get more funding that is split across multiple departments, because now you're forced to specialize. You're forced to have things like cancer treatment centers in your rural health unit because you're being extremely generalistic, because they need things, for example, like those specialized things that would not exist anymore because organ centers are gone. That means that on our world is much better because we deputize tasks, and this is what we told you, which is an important argument, because that means that the funding that we spend is less split. And this is important in the context of developing countries, because what we told you is that because we're a developing country, we have to be smart with how we deal with our budget. We cannot just fund everything into everywhere and we need to have a good disbursement of the way we actually create the access of treatment on different regions. We have already treated these problems in status quo, and we have linked as to why it is treated better on our world precisely because of the rise of different organ centers. So because their counterfactual fails in comparison to what already exists in status quo, they ought to automatically not make it to the next round. Issue then, and I want to make this issue quite clear, because it seems that side government wants to talk about access to care because they care about regional care, etc. And then you have to compare this with the certainty of care that we give on opposition. And this is the most generous I'll be in this reply speech. At best, they say that they increase the amount, for example, of access to general care in regional centers such as the provinces, etc. But again, the first call out still stands true. How do they bring the solvency, and what is the extent of solvency on their world? How does that solve the inherently regionally disjunct problem based on the funding that existed from these specialty centers? We give reasons why regional healthcare units are better on our world, because on our world it is where regional healthcare centers can focus on things like quality of life instead of being pressured to specialize. So in our world, we don't have to do advanced diagnostics for chronic kidney disease. It can be that regional health centers can focus on things like having dialysis machines. So if you want to talk about access and specific access to the different use cases of patients, it is much better in our world precisely because we're not focused to be hyper-specific to those kinds of things. That is important because the kinds of treatment that exist on their world are ones that are inherently disorganized, and it's unclear how they solve the problems that they want to talk about. Compare this with push on certain care, because we have increased knowledge, equipment, and staff, which is exclusive to treating these hyper-specific diseases. Further, we have things like deputization of tasks, forwarding of research, extension work, because this is a 1 versus 0. We have yes treatment, they have no treatment. It is a clearly better world in status quo. Clear off ballot, and I'm very proud.
We thank the previous speaker for that speech. Now to end the case for the entire bench and end the debate of the full, we now call on Governor. Thank you.
Hi. Oh. DLSU A is going to break the semis. They give 2 reasons. I'm going to give you 3. Because understand that their case already falls when they don't fulfill their main burden. In a This House Regrets debates, opposition side has to defend the status quo, and they never gave valid mechanisms or weighing metrics as to why status quo is preferable to the counterfactual that we gave to you. They can't just give impacts that you can have in the future. They have to weigh out why the state of the developing world right now is better than the counterfactual we give you. 3 reasons as to why we have to advance. First, on the contention on expense, on why it's more expensive on their side. Understand that what they try to tell us, specifically coming from DLO, is that everything is expensive anyway. Every hospital imports this because, that's the sole mechanism that they have in their side of the house. So in order for you to believe then, I'm going to point out the logical leaps you need to buy that, because you have to assume that all public hospitals in all developing states automatically need the most recent MRI scanners, the best wonder drugs coming from America or Europe. When you compare it to our mechanism that just proved that this is untrue, the main priority of the counterfactual in government is to make these hospitals not more modern, but more accessible in the first place. Because we have framed to you the state of the status quo. These hospitals are inaccessible. People have to wait 2 to 3 hours to go to get a checkup in the first place. So we want the bare minimum when they don't get at the end of the day. We don't need to be fancy. We need to be accessible. And so we want to make life for people in the mountains in Cordilleras easier, that they don't have to traverse rivers and mountains and go through heaven and earth just to get their child a paracetamol or something. But second, on the point on retrospectiveness, because the other positive argumentation coming from them is just, but you can, when you don't regret the rise of specialized centers, you free up the funding for the more state hospitals at the end of the day. This just doesn't fly, because when we prove to you that when you regret the rise in the first place, the funding that could have went to that expansion of these hospitals to make their capacities larger, to make the pace of the doctors and nurses are better, the funding comes from not funding the expansion of these specialized centers at the end of the day. That's the specific retroactive mechanism that you only get to be counterfactual in government. In opposition, they try to argue that, we can better allocate the funding so it's better used and more specific. But the prerequisite for that is you need that funding in the first place. And insofar as intuitively the status quo and the state of healthcare in developing states is just abhorrent and institutionally terrible. So even if you do cumulate or combine all of the funding in their side of the house, that funding is just going to like 5 people in Manila or New Delhi or Bangkok. Next, in terms of the prioritization of the types of diseases, this is the most contentious clash in the round. Government, we made it very clear we would rather prioritize the general and preventable diseases that these developing countries are suffering from, things like malaria. While their side, they defended and conceded that they are more willing to defend the specific ones that are more unpredictable at the end of the day, things like genetic mutations. Why do we win this clash in prioritization? We tell you that despite the fact that these are two different problems coming from both government and opposition, and sure, they might coexist at the end of the day, only government, and this is very, very important and debate winning, only government weighs stuff out and trades things off, while opposition barely does any trade-offs to begin with. We already traded off these specific diseases when we tell you that, sure, if we can't cure cancer, for example, but these hospitals in like PGH, for example, won't just leave cancer patients to die. They will try to mitigate and treat your symptoms. They're going to treat you if you have sepsis. Ow, I bit my tongue. They're going to treat you if you have sepsis at the end of the day. So even because you're not just going to let them die, we're not just going to leave them. Well, on their side of the house, they have to specifically trade off why exactly the inaccessibility of these things that could have come from the funding that went to the specialized center, why is that something they want to regret? In retrospectiveness, weighing everything off and just the vibe check mechanisms, DLSU A has to advance to semis. My mouth's bleeding. Bye-bye. Thank you.
All right, we thank the previous speaker for the speech, and we thank all the debaters for the round. You may now virtually cross the house. For the panel judges, kindly go to Discord room 2. Thank you, everyone.